we are going to finish with the last little bit of high-tech technology. And we are looking at the whole concept of refractive cataract surgery, and that is, how do we get the best possible quality of vision? Nobody comes into the office anymore and says, oh, you're the doctor, I'll do whatever you. It's like, no, they want to see up close, they want to see distance, they want to be able to do all the things they used to be able to do when they were a teenager. Well, we can do that, but it takes some work, and we'd like to kind of go over what we can now offer and are offering for our patients for the control of their corrections.
Yeah, so we already went over lenses versus laser, so we're now going to do lenses and laser in the same procedure. And we're going to talk about really why are we considering femtosecond laser-assisted cataract surgery is kind of our new standard and what we prefer to do in our clinic. So there's three big things that we're trying to accomplish with FLACS surgery, femtosecond laser-assisted cataract surgery. Number one, we're trying to improve safety. We want our patients to get in and out of the OR in the safest way possible. We're trying to improve accuracy. Everybody, I would argue that there's no such thing as a non-refractive cataract surgery. Would you say?
Everybody wants a result, and they'll have an opinion of what it is.
Exactly. Everybody has an opinion. They all have an expectation, whether they want to be completely independent of glasses or whether they want to be at least less dependent of glasses, or if they want a thin or thick prescription. They all have some motivation for what they want their vision to be after surgery. So all cataract surgery is refractive cataract surgery at this point. And then the third and final objective, we want to improve predictability. We want to have repeatable, predictable results with our refractive outcomes in the cataract surgery suite. Before we talk about why FLACS is becoming our standard and why the improvements that are being made, let's talk about the basic steps in cataract surgery just from a very high level. Number one, we have our main incision. We do one temporal incision, about 2.5 millimeters, and then one paracentesis incision off to the side. These incisions have to be watertight. We don't use sutures, we don't use glue. We want our incisions to be watertight so that the eyeball is not leaking. Number two, we're going to inject our viscoelastic agent, and that's going to protect the endothelium of the cornea. Number three, probably the most delicate part of the procedure is making the capsulorhexis. We want to have a nice circular capsulotomy to work with so we can extract that lens. And that part, probably, would you also agree, is one of the more tricky parts of the procedure?
It's one that we have traditionally done by hand, and we think we can get pretty good at it, but quite frankly, what couldn't be done better by a laser? And this is where we're going.
Following that, we have our hydrodissection. So we're going to now remove the lenticular matter, kind of separate it apart from the capsule. Think of the analogy I always use with our patients as a grape inside of a grape skin. We're trying to take the grape part, separate it from the grape skin through that little capsulorhexis hole. Number five, phacoemulsification. So this is our ultrasound. We're taking our phaco energy to try to kind of blast that lens up into a million little parts so we can easily remove it. That's our irrigation and aspiration step, taking the lens parts and physically removing them out of the eye. Phase 7, we're polishing the back surface of the capsule. We want to make sure that back capsular surface is completely clear, because if it's not, that's going to just develop quick posterior capsular opacification. The more polished we can get that, the better our outcomes, the less likely we're going to have to do a YAG quickly. Number 8, we're going to put the lens right in the same spot. So we've got that grape outside of its grape skin. We've got the grape skin girdle kind of intact still. We're going to put the new grape right in that same spot. Number 9, we're taking our viscoelastic out. We don't want to leave that in there or else our pressure is going to spike. And then finally, tonifying, antibiotics, make sure that our patient's safe moving out of the operating room. So if we really boil it down, there's 5 big steps in that process where things can go wrong. The incision, like I said, if it's not watertight, that means you've got either fluid coming out of the eye, or even more dangerously, you've got an avenue for bacteria to get in. The word endophthalmitis is kind of a curse word in our clinic. We don't like that. That is a very bad thing. So we want to make sure that we leave our patients as safe from harm's way as possible by having a watertight incision. Number 2, the capsulorhexis, as you're making that circle, that rhexis with a manual, a Sinskey hook or whatever you'd like to do it with, the capsule can rip. And if it rips, you're not going to leave a good girdle for the new lens to be held in place. Phacoemulsification, we need the phaco energy to get the lens out. The denser the cataract, the more energy. And what really absorbs that energy in a negative way is the cornea. So if we're using a lot of energy, the cornea is going to get beaten up. It's going to be swollen. You're going to have a patient who's going to take longer to heal. The fourth thing is centration. Now, as I said before, all of our cataract surgeries are now refractive cataract surgeries, right? All of our patients have some level of expectation. They want to be able to see as well as possible. If our lens is not perfectly on center with the axis of the optical system, you're going to have a subpar outcome. Now, not to mention with a multifocal or some sort of premium lens, if it's even more off-center, you're going to have a worse outcome. And then number 5, a lot of what we do is relaxing incision. We're addressing astigmatism at the corneal plane. And so relaxing incisions or astigmatic keratotomies made with a laser, more accurate, more repeatable. So FLACS is not really a new concept. I mean, it's kind of new. We've been doing it since 2010. The earlier versions of femtosecond lasers were more geared towards the main incisions, more towards the fragmentation of the lens, not so much focused on the refractive outcomes. Fast forward to 2022, the Lensar system, which is what we use in our surgical suite, is more focused on, well, it's improved the incision technique, it's improved the fragmentation, and now we are able to treat corneal incisions, and it's just much more customizable, making more of a just further advancement in the entire process. So a few benefits. Number 1, it's increasing precision and reproducibility of our capsulotomy. The capsulotomy is perfectly round each and every single time, which leads to a much better lens placement. We can fragment the lens, so now we know exactly what the lens is composed of. If somebody comes in with a really dense cataract, it has a different fragmentation technique. We're taking the lens out in a custom way every single time. We can now be more precise with our astigmatic correction. So we're making these arcuate incisions on the steep axis of the cornea. We can better pinpoint exactly where that steep axis is, and we can also account for variations intraoperatively or anatomical variations. Overall, we're improving our visual, refractive, and especially higher order aberration outcomes. So how do we talk about this to our patients? When they come in and we start having the basic discussion of, well, what do you want your experience to be? What do you want your outcome to be? I start talking, number 1, astigmatism, and everybody knows what that word is. It's a big word. Everybody, oh, I've got astigmatism, I've got astigmatism. And a lot of times we just kind of discount it because, well, that's a big fancy word for just saying that your prescription's, it's a part of your prescription. But I do ask you as optometrists, if I said that you had 0.75 diopters of astigmatism, would you correct for it in a pair of glasses or a pair of contact lens? Probably, right? Why wouldn't we put 0.75 diopters in a spectacle prescription? Well, before FLACS and before the Lensar system, we really weren't able to correct for that low amount. Toric lenses, toric IOLs, come in 1 to 1.5 diopters. So anything less than that was going uncorrected. So you've got patients who didn't think they had any astigmatism now ending up with about a diopter because of surgically induced astigmatism or just uncorrected corneal cell. We can improve the control of our premium lenses. So if I've got somebody who's interested in some sort of multifocal or depth of focus lens, we can more confidently tell them with the use of the laser, we can get the lens to sit where it's supposed to. With the premium lenses, they are paying something out of pocket. Inevitably, they're going to pay something. And with higher levels of out-of-pocket expense, you've got a higher level of expectation. Happiness equals expectations minus reality. So we want to make sure that our reality is as high as their expectations to leave us with a high level of happiness, a very happy patient. Our technology is now fully integrated into our clinic. All of our biometry talks to the operating room. Everything is completely integrated. And it's really a team approach. So like Dr. Vukich and I work in clinic, it's all about dealing with the same patient pre, post-operatively. The debate that we had earlier, we have that debate every day, talking about, well, which kind of lens is really a good option for this patient? How do we handle this patient? What kind of things are we looking for post-operatively? So it's really, truly a team approach.
So we're here to talk about FLACS, which it stands for Femtosecond Laser Assisted Cataract Surgery. And really what this does is it improves the steps of the surgery that we used to do by hand and creates a more consistent outcome. So what we're looking for is we want to optimize the position of the implant, and that means effective lens position. We have a more accurate correction of the overall power of the lens for where it sits, actually vertexing, you can think of it that way. We want to be able to treat the astigmatic correction, and to a lesser degree it fragments the lens. But let's kind of go through some of this one step at a time. All right, so we can fragment the lens, which is, kind of cool to watch, and basically now instead of using an instrument to do that, we use less power, less phaco power, and we're a little bit more gentle to the lens endothelium, or I'm sorry, the corneal endothelium. And so that is obviously a significant benefit. We use reduced phaco energy. There is less corneal edema as a result. And so if we look at endothelial cell loss with a 3-month post-op, there is some diminished amount of endothelial cell loss with the laser at 11% versus almost 14% with tradition. We'll take everything we can on the margins, and that is an improvement that we'll take. So this is an image of the femtosecond laser that is now just created the capsulotomy. It's very quick, and you can see that it is under applanation. It creates the capsulotomy. Now, did you see these little blue things right there? That is one of the biggest advantages that we have. That is iris registration. It's in fact capsular registration. So we now have the ability to use a toric implant in a way that is far more accurate than we ever could. Rather than marking the sclera, and then there's parallax, and then there's, you can be off by a little bit pretty easily. Now if you've got it at the level of the implant, you're going to get a very accurate placement. This is the unit that we're using. There are many different types, several different models, but this happens to be the latest generation and quite frankly the most sophisticated, and it does produce the ability to very accurately place the implant for a toric correction. It uses 6 Sime-Flug cameras. Importantly, it registers both the cornea, the lens depth, and interestingly, the lens itself density. So here's a short video.
Combination of Sime-Flug imaging, ray tracing, and 3D confocal structured illumination construct a 3D model of the anterior segment that includes the cornea and lens. Using the Ally system, the surgeon will have the opportunity to center the capsulorhexis on the pupil center or the anatomical lenticular axis. Cataract density imaging uniquely identifies nuclear morphology and categorizes density from 1 to 5. The fragmentation pattern and phacoparameters are then adapted according to density to reduce the combined energy delivered to the eye for optimal lens removal with the potential for faster visual recovery. The dual pulse laser is optimized for corneal incisions and lenticular fragmentation, reflected by the varying energy levels shown on screen during treatment.
Faster, quicker, less energy. For the first time, we have an objective measurement of how dense and thick the lens is. We use that to then program how much phaco power we need. We've never had that before. And so now, again, it's just one more step. We're pretty good at cataract surgery. We're working on the margins, and every little bit we can do better and more accurately simply adds to the end result. So here's the 3D reconstruction. And this is maybe a little bit subtle, but all of our toric implants have these 3 dots. And if you see this little nubbin right there? It's a little bit subtle, but it gives you, when you are co-managing the patients, and if there is an astigmatic correction that's been done, you can confirm with the slit lamp. You don't have to measure and do anything other than to say, oh yeah, there's the capsular tag, and it's right in perfect alignment with the toric lens markings. So we know the lens was not only placed in the right position, but it hasn't rotated. So again, that just gives a proof positive confirmation of where we are. Corneal incisions, we can do this with a laser, we can do this with a diamond blade. So this is something else the laser does. And quite frankly, this is something that is helpful, but maybe not necessarily 100% for the main incision. But what is critical is the arcuate incision planning. And by that I mean astigmatic control. We now have the ability with exquisite accuracy, length, position, and depth, do astigmatic relaxing incisions. We can treat a quarter diopter of astigmatism regularly. We can treat up to about a diopter and a quarter, which is where we'll draw the line and say, all right, that's where relaxing incisions, that's the sweet spot. Anything above that, we offer a toric implant. And so these are the types of parameters that we find that we know we can get the best possible quality of vision. And so if you want to use just a toric implant, that's absolutely going to be the way we use this laser. If we use the light adjustable lens, again, we just have that next level of exquisite control. What about the capsulotomy? If this looks old-fashioned, it's because the way we've been doing capsulotomies for years. I mean, I can imagine someday my grandchildren will say, Grandpa, tell me again how you used to use a bent needle to tear a hole in the lens of a human eye. And I'm like, well, yeah, that's kind of what we do. But not anymore. So this has been replaced by the ability to use a laser to create a very, very high quality capsulorhexis. And what does that mean? Well, it means that it's perfectly centered. We get perfect overlap of the implant, so we know we don't get tip and tilt, and that is important for a pantoscopic tilt and induced astigmatism. It is for centration and better outcomes. These are cases that I did, and I almost thought I was pretty good at this. These are my manual capsulotomies. Yeah, and they're pretty round, pretty much. These are the same capsulotomies done with a laser that I did on other patients, and I don't think I need to say a lot. Those are consistent and they're real and they are better. All right, so why is that better? It produces a much more centered implant, a more reliable predictive implant position, and a better refractive outcome.
So I already alluded to the importance of centration of the IOL, and why does that really matter? Well, the capsulorhexis, if you don't have good optical overlap, like Dr. Vukich mentioned, you're going to have tip and tilt. You're more likely to induce coma, trefoil, all these sort of higher order aberrations, which we don't really want. If it's oversized, the lens could actually tilt. You could have a loose haptic, and you're just likely to induce all these problems. Now, multifocal, depth of focus lenses, they all rely on higher order aberration. That's how they function. They are splitting light. So we are introducing more higher order aberrations into a system that already is prone to higher order aberrations. So we've got this really, really high expectation by our patient. They're leaving unhappy because now all of a sudden they've got more glare, they've got more halos, or they're almost seeing this sort of monocular diplopic image, which is problematic. So this was actually a study that was done not long ago, 2023, looking at 261 eyes, specifically looking at the Symphony lens. The Symphony lens is a lens that we still use. It's a depth of focus lens which gets good distance and intermediate visual acuity. Looked at 131 FLACS eyes, 130 conventionals, and statistically significant improvement in IOL centration in the FLACS category. Significantly lower HOAs, and there was superior depth of focus at -1 diopter. So the depth of focus lens is working better with a FLACS procedure. Just a couple graphics from that same study. So over here you're looking at decentration, or centration of the capsulorhexis. So the femto group being the blue, the red being the phaco, more traditional method. Clearly you can see that we're much more centered with the blue. Over here, our defocus curve, more defocus in a positive way in our femto group, especially at 1 diopter here. So the precise capsulotomy, why is that important? Well, it reduces the need to go deep with the phaco tip. Again, we want to get all that lens material out, but the deeper you go, the higher chance you have at rupturing that posterior capsule. If you rupture a posterior capsule, you're going to have vitreous coming forward where you don't want it, and you're looking at a subsequent anterior vitrectomy, which leaves the patient more prone for things like peripheral retinal tears, retinal detachments, bad stuff. So we like to keep the vitreous where it's supposed to be, in the back. Posterior capsular rupture rate, it is inevitable. It will happen sometimes. We like to think it doesn't happen often, but it does. In FLACS size, it happens 0 to 2% of the time. Normally, it's anywhere from 0 to 5. So we are lowering that rate down significantly. And there's a much less phacoemulsification time with our FLACS group. So Dr. Vukich already mentioned iris registration, and why is that important? Well, some of the other lasers that we have on the market use external cues to determine how the eye is rotating. The FLACS system that we use, the Lensar system, actually looks at the iris architecture itself. And we gathered that information from our pentacam in our clinic, preoperatively. So we're getting landmarks on the iris, and now we're able to account for torsion control. So when the patient is in a supine position, the eye actually does cyclorotate, and it rotates a non-insignificant amount, up to a couple degrees, which could definitely influence our toric correction and our astigmatic correction. So again, we get that from our iris registration on the pentacam. Now, how much rotation, or how far off do we have to be from our astigmatic correction for it to be significant? Is it 1 degree? Is it 5 degrees? Well, 1 degree off axis is about 3.5, 3.25% of reduction in your astigmatic correction. So let's expand on that a little bit more. Let's say 5 degrees is about 17% reduction in your cylindrical power. 10, 15, 30 degrees, you can do the math. It gets bigger, bigger, bigger. You obviously want to be close on. Now, we all know as optometrists the Lars rule, right? We learned this in our contact lens classes. If you put a contact lens on the cornea and it rotates by 5 degrees, well, number one, that patient's probably not thrilled with their contact lenses. How do we deal with that? Well, we add 5 degrees to the prescription to compensate. It's not that easy in surgery. If you're off 5 degrees, that patient is unhappy. How do we fix it? Well, you're looking at more surgery. We need to be more accurate in the operating room. And that's how we accomplish it. Now we have the iris registration technology that helps us compensate for those variables in the operating suite. So cyclorotation, how do we get it? Like I said, number one, it happens when the patient is in a supine position. The eye will rotate a certain degree. But it can also happen from extrinsic factors such as surgical manipulation, the suction from the laser, or other variables such as free-floating operating room beds. You have various different ways that you can induce cyclorotation. So in fact, I asked how much cyclorotation do we actually get? Well, this study looked at it, 5.81 diopters on average. That's a range of 0 to 17 degrees. That's a huge range. 17 degrees of cyclorotation, that means 17 degrees of variability from something that we could already control. Not to mention that the lens could still rotate even further, or our surgical procedures could go less than perfect. That's 17 degrees plus whatever other variables you have. You're looking at a 30-degree potential. So Dr. Vukich already mentioned the nubs as well. If you look right here, there they are. So we use these to guide our toric axis markers. Dr. Vukich, how do you normally do toric markers in the operating room?
Previous to this, we would have the patient sit up. We would use a skin marker. We would anesthetize the cornea, use a skin marker, and try our best to identify the 12 o'clock and 6 o'clock meridian. That gives us a reference point. We then lay the patient down, and there's often cyclorotation after they lay back. We then use something called a Mendez ring. We try to line that up, and then we put a mark where we want it to be. These marks, the thinnest you can get them is 5 degrees, and that's if it doesn't bleed or doesn't, fade between the time they're in the pre-op area and back. So there's just inherently error in this. And so I'm sure that all of you have seen patients who got a toric IOL who still had 3/4 of a diopter of astigmatism left. And is it because we didn't do a good job? It's like, no, it's because we did the best job we could. And the reality is getting the lens exactly where you want it isn't easy. Now we're using the Femtosecond laser, and we have these absolute at the plane where the implant sits, this area that gives us exactly where the implant goes. And that is how we get spot on toric control. It's really changed my opinion of toric lenses, in all honesty, because we can be accurate at a level that we never could before.
Yeah, it seems like a very old school way of doing it, but that's how we've done it up until now, which is crazy to me. We've had all this technology. Now we are just starting to figure out, oh yeah, the toric lens rotating by 5 degrees actually matters. And so now we can actually do it down to the degree. So again, the advantages of this, we're able to better center our lenses, especially our premium lenses, our advanced technology lens. We can much more accurately control astigmatism. So every patient, when they come in with an expectation, we can better meet that expectation.
So we touched on astigmatic keratectomies. This is kind of a blast from the past. Like this whole idea of weakening the cornea so accurately that the corneal shape changes in a predictable way. It's called radial keratotomy, and we knew that that was not a great way to go for myopic control. But it turns out that for astigmatic control, it can be very, very accurate for small degrees of astigmatism. And I think, as Dr. Bruns pointed out, I don't think that any of us would ignore 3/4 diopter of astigmatism in a pair of glasses that we're going to prescribe. You just, it doesn't matter. Well, because it does matter. It's a quality of vision issue. Now we can do smaller corrections with astigmatic keratectomies. The very same registration that looks where the eye cyclorotates. Now the cornea itself is imaged three-dimensionally. We get a very up to 90% depth, and we can then provide incisions of a precise length, and that allows astigmatic control up to about 1.25 diopters, and that's where we draw the line. And so that has really changed how we think about it. There's something else. Traditionally, astigmatic keratectomies have been done perpendicular to the level of the cornea. And there was some thought that, well, that's just kind of how you do it because that's where the foot plates go. Now, with the laser, we can do it on a bevel. And that bevel allows a more controlled change in the shape of the cornea that is more permanent. It doesn't fade away. It stays there. So again, these are the sort of things that we've learned, and quite frankly, the things we couldn't do absent the use of a laser to do that. So what are the accuracies? Here you can see on the left, pre-op cornea, just under 0.7 diopters, reduced to less than 1/4 diopter. Post-operative astigmatism, less than 1/2 diopter, 91%, 100% less than 3/4 of a diopter. So again, these are the sort of things that we can provide such a high level of confidence. And again, here is just simply a different study that shows these arcuate incisions produce significant reduction in astigmatism. And this is a retrospective review of patients with less than 1.35 diopters of corneal astigmatism before and after. And 95%, 94.9% were less than 1/2 diopter when we're done. And that's really the sweet spot. That's where we want to be. Here's where I touched on the beveled astigmatic change. It allows a tectonic shift as opposed to a splaying, which is very different from an architectural standpoint, and again, only possible when using a laser. And again, here is just simply more data to support that it is the longevity, it doesn't fade, that up to a year, still less than 1/4 diopter of astigmatism remains, having started with almost a full diopter to begin with. So is this worthwhile? Absolutely. Is this something that we present to our patients and say, are you interested in having the highest level of quality vision without glasses? We can do that. And I think we really touched on this. These are the changes in the capsule, the capsulotomy that then gives us the place where we can place a toric IOL. So our cutoff now is about 1.25 diopter, 1.5 for incisional or astigmatic keratectomies with the laser. And then after that, we offer a toric lens. And the toric lens obviously can be used at a much higher level. So we've seen this. We've talked a little bit about rotation. You can absolutely see this at the slit lamp post-op day 1 where they are and where they stay. So when you're seeing your patient's back, just when their dilated exam is there, you can tell them, yep, your implant's right where we wanted it.
Go back to that slide real quick. Can you go back?
Okay, yeah.
Look at Day one. That looks off to me. Does it not?
Well, yeah.
This one. This one right here.
This one?
Okay. Can't see your stick so close.
Yeah, okay. All right, so yeah, that may be 5 degrees off. Yeah,
So what do
no,
you
you're
do with that patient?
What do you do about that? Well, then you check and you see where you are. I mean, if they still have a 3/4 diopter, are we going to go back in and adjust that? Maybe. We can do that at the slit lamp. Then you start using common sense, all right? It could be these lenses can rotate slightly, and so again, then you use common sense and say, all right, what do we have? Almost certainly, even with that, they're better than they were before. And so maybe we lost 10% of the toric power, still got 90% correction. And I can tell you that's way better than it would have been without. All right, clockwise rotation. Let's kind of move along here. I think we've really kind of driven home the point that astigmatic correction is critical and that we can do a better job than we ever could before. We have the data to support this, multiple studies, and then just pragmatically, how are our patients doing when we see them back? And that's really where the proof of the pudding is. Again, looking at post-op astigmatic corrections from a pre-op of 1 down to less than 0.2 diopters, 0.11 diopters. That's what we're looking for. So we know that this is important. We know if we're going to get the best results, we have to get these lenses aligned. We now have the technology to help us do that and do it better. So what is the take-home density? Take-home for density, we can use less laser power to begin with. We know how thick the lens is, we know how dense the lens is, and we use that then to set laser power settings. Again, all of these things are integrated into creating a platform that provides the information we need to do the best possible way. So I think what we have is really just a confluence of innovation with technology, with marginal improvement, because we've always done quite well, and better results because of all of those things that we pay attention to. It's each step of the way we need to make good decisions based on good data. We talked a little bit earlier about endothelial cell loss being mitigated. That makes sense. The safety, because of the fact that we have a better, more robust capsulotomy. So can we do a better job? The answer is yes. Are we doing a better job? The answer is yes. Your patients will be offered this. Now, there is a cost associated with this. It's a premium outcome for the astigmatic control. And again, we try to make this as affordable as possible. So there is a decision that comes into play. But at the end of the day, vision is critical, vision is important. It's how you enjoy the world around you. And I think when patients really understand that, it becomes something that they can easily say, yeah, I want to see as well as I can.
So who is a good candidate for FLACS? Well, most people are, as long as you have a certain level of corneal astigmatism. Regular corneal astigmatism, again, we can do up to 1.25 diopters. We don't really want anterior segment pathology. The cornea's got to be pretty clear. Blebs, we are using suction for this procedure, so we don't want a bleb or anything that's going to limit the amount of suction that we can get. Or patients with moderate to severe dry eye. They should be good dilators. They have to sit under the laser. This is now a 2-step procedure. We do the laser before bringing the patient into the operating room, so now there's 2 sets. They have to have adequate palpebral fissures to sit with the suction. And people with hypermature or white cataracts are great candidates for this because we're going to use less energy to get that lens out. Normally, it would have been kind of a tough surgery to get that thing out of there, but now we can do it quicker and easier. So, patient over here, perfectly regular pentacam. We like to see that topography, the symmetry. That's got 3 diopters of cylinder. Can we get all of that with an astigmatic keratotomy or a limbo relaxing incision? No, but we can definitely debulk it. For that patient, we could easily do a toric lens, though, and we would see the little nubbins on the capsule. Patient over here, again, pretty regular. You know where the axis is. It's a low level of astigmatism, but we would definitely have the ability to treat that low with the FLACS system. Who's not a good candidate? People who don't dilate well, or they don't dilate enough for the intended treatment zones. If they have any existing corneal implants, intacts, any sort of prior corneal surgery wouldn't be a good patient for this. We need to make sure that their cornea is regular. We really don't want to see patients with keratoconus because how do you determine where the axis of refractive correction is in those patients? It's really hard. It's very irregular. People with severe dry eye or history of herpes zoster or simplex keratitis wouldn't be good candidates for this as well. So patient over here on the left, where's the axis? I don't know. It's somewhere here, but we don't really know, not enough with enough certainty to really guide an astigmatism treatment. Or this one over here, this is all over the place. I'm pretty sure this is a post-RK eye. I don't know where the axis is. Do you?
If in doubt, my rule of thumb for topography is if it catches your attention and you look at it for more than 5 seconds, there's something abnormal or atypical, and they're probably not a good candidate for incisional techniques. They might be a good candidate for a toric lens, but I would not. So that kind of looks like contact lens induced irregularity, or could be post-RK. This one, a tight little bow tie centrally. You got to be really careful with those. So I would not treat that as well. So again, this is where experience comes into play.
All right, just a quick little case. So this is a guy that we did a little while ago. So he was a brewer. He's actually one of the official taste testers, which is the coolest job ever for Molson Coors here in town.
He invited us actually to come visit with him, which was amazing. Anyway.
So he had a little bit of amblyopia in his right eye. He was patched as a kid. He came looking for LASIK. That was his prescription. So +6, -250, 27, correctable to 20/30 in the right, +5, -350, 180 in the left. So high hyperope, high astigmat with a less than 100% visual potential in the right eye because of the amblyopia. Topography is perfectly regular. You have no doubt where the cylinder, the axis is in either eye. He's a great candidate for a lot of different things we could talk about. What do we need to consider, though? His age, he's young, he's 30. We want to make sure that we're going to do something. If we're going to do anything, it's going to last long enough because he's going to get some mileage out of these things. His prescription, obviously, his topography, yes, definitely got to consider that. Can we do LASIK?
Not for a high hyperope. Yeah. Certainly for a young patient, I would not. He won't get the result he's looking for.
Nope. ICL can't do that either. He's a hyperope. We can't do that. RLE, that's what we're going to do. Right.
And this is a great discussion about a young patient for an elective refractive lens exchange. Is that the right thing to do? Well, at that level of correction, it was interfering with his job as a microbiologist in an industry, the beer industry. It's all microbiology. It's all very high tech to get consistency in the strains of bacteria that they use and what have you. He needed better vision to do his job. RLE, absolutely. Mm-hmm.
And so the discussion comes down to which lens are we going to use. Well, with him, we wanted to get a little depth of focus because he is young. He's never been a presbyope before, so we wanted to get something. So we ended up doing LEL. And this is not an LAL talk, but it does give us the depth of focus that he needed. Now, the thing about the LAL is that we can only get about 2 diopters of cylinder. With him, he was expected to have about a diopter to a diopter and a half of residual corneal astigmatism. So how do we tackle that? Well, we want to be accurate, number one, but one thing we can do is use the astigmatic keratotomies, the limbo-relaxing incisions, to debulk the corneal astigmatism to bring the residual within the range of what the LAL could do. So we can add to, we were expecting about 0.75 to 1 1/4 or 1 3/4 based on all of our calculations. So this is what his plan looked like. Right eye, we're going to do a long arcuate incision along his superior and inferior limbus. Left eye, same thing, just along his steep axis on his topography that we took preoperatively. So when we saw him before his first adjustment, his right eye, actually the calculations worked out almost exactly what we wanted them to be. His right eye had 3/4 diopters left residual, which is well within the range of what we can do with the LAL. And the left eye, which is his dominant eye, had still 2 diopters. Now, being his dominant eye, and we needed him to have the best possible vision out of that one, understanding that his right eye was still going to be a little bit less, we wanted to get as much possible correction as we could, or at least leave ourselves with enough wiggle room to work with once we got to the light treatments. His final outcome, he ended up electing to do a little bit of a blend. Even with his amblyopic eye, he still maintained really good function. He was J3 in his right eye with a minus 1.5 diopter myopia. Overall, 2015, J3. So he was very, very happy. So in conclusion, improving safety, yes, less posterior capsular ruptures, quicker visual recovery, cornea rebounds quicker, improved accuracy, and improved predictability. Thank you very much.
So I think that the thing to take home is how you treat your patients. Think about how would you treat your spouse, your parents, your father-in-law. How would you treat someone who is near and dear to you? If you use that same level of concern for your patients, you're never going to go too far wrong at all. So at this point, I want to thank all of you for giving up a beautiful Sunday in the spring. I can tell you that it means a lot to us. We hope it's been worthwhile. We're already planning the next event, and it's going to be, 6 months or 8 months from now. But we hope this has been worthwhile. We want to make it better every time. Thank you to the speakers. Thank you, Dr. Parceau. That was amazing. We'll continue to bring in the highest quality lecturers and content. Again, we want to partner with you. And we have our newest addition to the team, Rebecca, who is going to be part of that process to make it even smoother. So thank you, thank you, thank you.